Hello everyone, welcome to Economic Evaluation in Healthcare. This is 4 credit hours and the subject code is MSPH2074. So the course learning outcome for today is to explain the strengths, limitations and implications of economic evaluations, economic health programs. So the introduction for the session for today is to introduce the need for economic evaluation, the basic types of economic evaluation, perspectives of an economic analysis, and economic evaluation is a craft rather than an exact science. So it's more of the art of decision making. The importance here is that uh, at present, resources are being limited, while on the other hand, costs of health programs, utilities are rising in addition to more innovative and technological advancements. Nowadays, nothing is so cheap, everything is expensive. Therefore, economic evaluation also helps to prioritize the programs, make the best decision for optimal resource allocation, and economic evaluations are important tools for assessing economic feasibility and efficiency of health interventions. So the basic evaluation are divided into uh, the cost benefit analysis and the cost effective analysis, the cost utility analysis, and the cost minimization analysis. These are the 4 basic types of cost of economic evaluation in healthcare. So, um, cost effectiveness analysis or CEA and cost utility analysis or CUA and cost benefit analysis or CBA are all compared to money units. All of them are basically for how much you can benefit and how much you can minimize, how much you can effectively use in terms of money. They have monetary units. And the identification of consequences is that the CEA has single effect of interest because it's effective analysis, common to both alternatives but achieved to different degrees. While the cost utility analysis is more of a single multiple effects but not necessarily common to both alternatives. While lastly, finally, here is single or multiple effects not necessarily common to both alternatives, and therefore those are the identification of consequences. For the cultures uh, and values and beliefs, some values should not be reprimanded or misinterpreted because of the cost that you would like to save. And important and lasting beliefs or ideals shared by the members of a culture about what is good or bad and desirable and undesirable should be respected. Values have major influence on a person's behavior and attitude and serve as a broad guidelines in all situations. And therefore, cultures and values and beliefs have some common business values that have fairness in innovation and community involvement. And some looks at profit, termination and retrenchments, those are some of the profits that they are looking for. And those are the culture's values and beliefs. So, thank you very much for topic number 1. We will now go to topic number 2, measuring cost. Topic number 2 explains the strength, limitations, and implications of economic evaluations of health programs. So, in addition to those explanations, we would like to combine medical and economic data that can be used in health economic evaluation. So, what is the total cost when you do a measuring cost? The total cost is the actual cost incurred in the production of a given level of output. In other words, the total cost expenses or the cost incurred, both explicit and implicit, on the resources to obtain a certain level of output is called the total cost. everything that you have in total, add it all, sum it all up. Those are called the total cost. But the fixed cost, on the other hand, is are the expenses that do not change because it's already fixed in proportion to the activity of a business and within the relevant period or scale of production. That means, like when you go to the mall, okay, you cannot bargain. Those are fixed costs. Or uh, when you have a tag price on a hospital bill, those are fixed costs. That means there's no way of bargaining or of giving any um, negotiations because it's fixed. While the variable costs are, on the other hand, are production costs that changes in proportion to the amount of goods that are produced. In other words, for every good that is produced, it's variable. It increases by the same amount. For example, the vaccine long time ago, they are free of charge. 1 year ago, 2 years ago, they're free of charge. Now, if you want a vaccine, you can pay for it. They are asking for money because people need to travel. People needs those certifications, and they're getting those variable costs at hand now. So it is the opposite of the fixed cost. While the average cost, on the other hand, uh, these are the average cost per unit of total cost of production obtained by dividing the total cost to the total output. So the average is like the mean, the average of what you had, total it up on a quantity, and divide it by the quantity. Total it up, summation of all the costs, and then count the number of units or the total outputs, and then divided it, and then you got the average. By per unit cost of production, all fixed and variable costs, all of it are taken into consideration. The total cost of this, the average cost, the fixed cost, the variable cost, and thus it is also called as per unit total cost. That's the average cost. So the marginal cost, on the other hand, is the additional cost incurred for the production of an additional unit of output. This is the formula. Marginal cost is equal to change in the total cost divided by change in quantity produced. Because if you have a change in the total cost, you can minus it and or add it all up in the change of total cost, or get the difference when you minus. There's a regular total cost, and there's the new total cost, or change of total cost. You minus that from the regular, get the difference, and then that answer you divide it into the quantity produced. The formula is calculated by dividing it. So the marginal cost is calculated by dividing the change in total cost and the change in quantity. That's the formula for the marginal cost. So, for example, you have, for a long time ago, you have $6,000, and then suddenly it changed to 5,000. So you minus the 5,000 from 6,000, you get 1,000. So if you have 1,000, the total output should be maybe units. It's about 500 units, and there's a difference between 1,500 to 1,000. Before it's 1,500. When it changed to $5,000, it becomes 1,000 per unit. The total units you have is only 1,000 because it 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 reduces. So what you're gonna do is you get the difference from the change in total cost, and then divide it into the units, and then you get the marginal cost. It's called output by 1 unit. So that's your output. That's what you call the marginal cost. So when you try to calculate unit costs, the unit cost is determined by combining the variable cost and fixed cost. So you combine the variable and the fixed, dividing by the total number of units produced. For example, if the assumed total fixed cost is 40,000 and the variable cost is 20, so you get 60, and you produce about 2,000 US dollars per unit. 60 divided by 2,000 equals 30,000. 60,000 divided by 2,000 is equals to 30,000. And discounting costs are the old product are cheaper than the new products. That's called discounting cost. For example, your food is going to waste in 1 month, expiring in 1 month. So what are you gonna do? You're gonna give discounts. Or for example, you have a new mechanical ventilator going on called the Galileo 2020, the Galileo 2022. Or for example, you have the Gomco suction machine. It's so old already. How much are you going to let them rent for this? Therefore, it goes down. A cost of $1 million, which will be incurred in the next period of a year, requires less than 1 million of current resources to be set aside to cover the future liabilities. That means it becomes a liability. And because the funds can be invested with a positive rate of return, therefore you have to put it lower instead of wasting money. The longer the time, the older the product, the cheaper it becomes, the more it expires. In order for you not to keep expired things, better sell it at a cheaper rate. You earn profit rather than it becomes a liability. It still remains to be a profit. The more distant the future is the same real cost and is incurred, the less of current resources that is required to meet it. The present value of 1 million occurred in 10 years will be lower, becomes maybe 708 and 919. But the 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 newer the product, the more expensive you can demand for it because it still has a lot of values. So, should the cost and quality of life years be discounted at the same rate? That's the biggest question. Should the cost and quality of life years be discounted at the same rate? Whether there are constraints on healthcare expenditures and whether the cost effectiveness threshold is expected to grow over time, or whether the consumption value of health is expected to grow. That's the quality of life years. And therefore, do you think you should discount a very old syringe pump rental if the quality of life years is the same as the new high technology syringe pump? That's the biggest question. Are you looking at quality of life years or are you looking at the cost of the product? It's so old, obsolete, but the quality of life years are the same rate as what you use. So that is the biggest question, and usually the answer is no. Uh, no, because the product is old. Therefore, you must give cheaper rates because the older the product, the cheaper it becomes. Despite the fact that it gives the same quality of life years that you can incur through the person that you need to give it to. Therefore, a discount is still necessary. Yes, the cost should be discounted because the resources that you're using are already way past its prestige. Therefore, it's a liability and no more a benefit. Taking capital cost, taking total capital amount of outstanding debt plus amount of preference share plus the market value of the common equity are the total capital. In this life, where you belong to the generation 5.5 or 5.0, capitalism is definitely the name of the game. Everything that you give, you must put a capital on it. Therefore, an interest, they call it an interest, they call it something that you can take home. There's um, a capital, the one that you invest in, that's your capital. And capitalism nowadays is the name of the game of everyone. If no matter, regardless of what quality of life you're looking for, whether it's a cancer drug or whether it's an epinephrine or as simple as vitamins and minerals, capitalism is always there, especially for beauty products, because beauty products nowadays are very expensive because of capitalism. Instead of selling it as $1, they're gonna sell it $10 because people wants to be benefiting from the beauty products that they have, and therefore capitalism is one of the gameplay where the weightage of preference share is equal to the amount of preference share divided by the total capital. And if you want to be a capitalist, you have to invest a lot of money for the product that you're trying to use. So the volunteer time is more of those professionals that has no more expenditures that you can give them. That means the volunteer time is usually for healthcare professionals that do not need salary wages. The volunteer time, professionals with high ranking bachelor's degree or with high ranking um, certificates are not being paid for their wages. It is possible to work out the economic value that the volunteers make to your organization by multiplying the volunteers by hours and hourly wage. So usually volunteers, especially the professional volunteers, they're given salary per hour, and this could be the national minimum wage or median hourly wage. And the minimum wage probably underestimates the value, while the wage of median may overestimate it. That is the volunteer time. Some volunteers are being paid for per hour, but those are the minimum wages, despite the fact that they are highly professionals, highly qualified, extremely expert in that sense. But this is where some companies in healthcare industries can save a lot of funds because um, there's so much investments being going on healthcare, especially those people who cannot afford, looking for um, those donations, looking for sponsorships. And if you look for donations and sponsorship, this means that you need to save money. This means that you need to reduce down the cost. Donation means reduction of wages of employees. And all healthcares are having this kind of problem with donations and sponsorships, and therefore they look for volunteers who does not require a high capital payment in order for them to save funds and give that fund to the donation rather than give it to the wages for the employees. And valuing productivity, when you value productivity, you can measure employee productivity with the labor productivity equation. The total output divided by the total input is the labor productivity, employer productivity. Let's say your company generated $80,000 worth of goods and services as an output. Now, utilizing $1,500 on labor hours, which is an input, to calculate that, the labor productivity would divide 80,000 by 1,500 equals to $53. That's the labor output, or the productivity. That is the productivity that you have. So thank you for your time with the topic number two. Now we go to the topic number three, which is the cost effective analysis. And this is the combination of medical and economic data that can be used in health economic evaluation. Uh, so we're going to explain strengths, limitations, and implications of economic evaluations of health programs and design competent economic evaluation decisions. So, what do you mean by CEA? CEA is cost effective analysis. That's the first one that you need to remember for economic evaluation in healthcare. In this method of analysis, cost is measured against the effectiveness of the intervention. Do I need to pay for this? So, That's the money. The cost is the money. It's in dollars or in currencies that you want to give. Is it worth it? That's the question. So the consequences of the comparing intervention may vary here, and the outcome of interventions are usually identical. However, the cost may be higher than the other interventions. So let's try to weigh things out. Weigh things out. What is the outcome? It's the same. Why do you need to pay for more if you can have the other one? That's why they're using generic names of medications, while some millionaires don't like generic names. They want branded names. But the outcome is still the same. Cost effective analysis, you have to weigh things on the cost. Look at a single quantified effectiveness measure of the cost per unit. For example, the cost in dollars of a life saved and the least cost way of supplying electricity or water to the community. How effective is the spending of the cost? What is the outcome? Is it the same? So you balance the cost effective analysis, weigh things out. Principles is other frequent costs of effectiveness studies are those of prevention or diagnostic intervention. These tend to focus on the specific impact of the intervention as opposed to the broader health of the patient. On the other hand, cost-effective analysis is of most use in situation where a decision maker operating with a given budget is considering a limited range of options within a given field. Like for example, option 1, give chemo, then die and lose money. Option 2, don't give chemo and die but save money. So those are the things that you have to ask yourself. Is it effective? Is it worth it? What am I going to do if I give this? Will I lose money? And in the end, it's still dead. That's what you call the cost-effective analysis, the cost-effectiveness. Cost-effective analysis is the limitation of this analysis is that it is difficult to compare the interventions with differing natural effects. Like what we said on the introduction of this topic is that look at the culture, look at the value of a situation wherein you're analyzing the effectiveness of your cost. The limitation sometimes is outweighing the value. Interventions which are focused on looking at life years saved cannot be compared with other interventions which are focusing on improving physical functioning. Like for example, when you're performing CPR, cardiopulmonary resuscitation, and you know that it's already vegetable after 5 minutes of golden minutes of resuscitation, you're brain dead. Should you waste more drugs and efforts on resuscitating someone who's already dead for more than 1 hour, or looking at the value of saving lives? What are your priorities? Is it the natural effect of the value of saving life or cost effective analysis? It's not cost effective, but there are some implications more to the value of saving life. And if you save life, will the physical functioning occur? Because if you're vegetable, even though you're alive, your heart pumps, your kidney works, your lungs expands, but your brain is dead. You can't work, you can't eat on your own, you can't move, you can't go to the toilet. Everybody will be so busy taking care of you, which in the end you will never be able to get yourself back into the physical functioning that you have. That is cost effective analysis. And this is the weighing things of different interventions differing from the natural effects that you want, whether you want to save or not to save. An example, suppose that our interest is the prolongation of life after renal failure. You're having dialysis. Okay, you want to prolong the life of having dialysis, and that we are comparing the costs and consequences of the hospital dialysis with kidney transplantation. In this case, outcome of interest of life years gained is common to both programs. But renal transplant is more expensive than dialysis. And who wants to give their kidneys? Only dead people, only those who are dying who wants to give their kidneys. However, the programs may have differential success in achieving this outcome as well as differential costs. The more expensive is kidney transplant. Dialysis is also expensive but lesser expensive than kidney transplant. If you have a donor that does not require payments, for example, the brother or the sister giving away the same genetic code, because they need to match the codes, they need to match the genetic codes, and they need to know whether the organ will be rejected, so they have to have a matching of their their kidneys, whether it will be accepted or rejected by the body. So that is when the dialysis moves away and the kidney transplantation comes in, because you weigh things out, and which one is cost effective, the better the better the cost of your savings will be. And the outcome is still the same. Maybe they will live for 10 years and die, or maybe they will live for 20 years and die. So both are the same. 10 years of dialysis, 20 years of dialysis, 20 years of kidney transplant, 20 years of kidney transplant. But the costs are different. So these are the example. And two forms of cost-effective analysis. Number one is the constant effect. What is this? This uses the least cost analysis to determine the lowest cost alternative for meeting the same level of benefits, including intangible benefits. The number two method is cost effectiveness ratio. It calculates the cost per unit of benefit. This goes to the constant effect, because the cost per unit of benefit are both benefits and costs that varies across alternatives. So the cost effectiveness ratio calculates the per unit of benefit, and constant effects uses the least cost analysis to determine the lowest cost alternative for meeting the same level of benefits. So the same level of benefits, including intangible benefits, are on the constant effect, and what you get from the constant effect will be an effect of the ratio of the method number two, because both benefits and costs vary across alternative, and therefore calculates per unit of benefits. So there's a per unit of benefits on the number one method going to the number two method. So let's see the constant effect of CEA. What do you mean by constant effect, which is method number one? Method number one is constant effect of CEAs, or cost-effective analysis. Selection of criteria is to choose the alternative that has the lowest present value of cost. And the outcome may be a function of the rate of discount and may switch with change in discount rate. So, if it's discounted, get it. Choosing from two types of water pipes of different diameter, for example, in your community health, doing public health, there's a water sanitation going on, and you have two types of water pipes of different diameters. Yield the same quantity and quality of water per day. Smaller pipes have lower investments and costs, but higher operating or pumping costs. So better take the bigger pipes, because bigger pipes are cheaper in their pumping action or pumping cost, and the investments is there. So if you want the community to have water, clean water and potable water, because water can cure a lot of diseases, and in the community, in the public health, water is so much important. It's very important to build and establish a community in a public health setting, because water is life, and therefore you have to get the most effective constant effect, the cost effective analysis of the constant effect, choosing between brand A and brand B while looking at the money that they incur. So the cost effective ratio of effectiveness ratio of cost effective analysis looks at the benefits that are simply measured as the number of premature deaths are prevented. For example, DPT, or Bacillus calmette guarin, and those are vaccinations for children, campaign for children, or AIDS treatment, just for example, an AIDS treatment program for infected patients. The cost per child vaccination or per patient will be computed in this case. And here, the purpose is to see which program yields more value per dollar of expenditure. So, if you're going to spend more on AIDS treatment, better get a system, a program called DPT BCG vaccination campaign, because it's only one time, you know? While AIDS treatment is forever. You're going to give them every day, every month, or every 6 months these kinds of medications, and it will cost you a lot. While DPT BCG, one time shot, then you're finished. No more. Next patient, next patient. So which one costs a lot? DPT vaccination or AIDS treatment? Therefore, DPT BCG vaccination will be the chosen campaign. So there's another CEA option here called Brand A and Brand B. This is the Brand A called Program A, and the Brand B is called Comparator. So this is what you call economic evaluation that involves comparative analysis of alternative course of action. Consequences A, is it the same as compared to consequences B? So this is the consequence B. And is it the same with the consequence A? So if it's the same with the consequence A and consequence B, so choose the lesser cost, because the lesser cost will give you more benefit. So what what about marginal analysis? A marginal analysis is margin, the margin. Of course you can still waste money. This is what it's trying to tell you. Why not? Go ahead, waste money. But you have a margin. You should have a margin. Not all of it getting bankrupt. But make a margin. This is an examination of an additional benefit of an activity compared to the additional cost incurred by the same activity. Companies use marginal analysis as a decision-making tool to help them maximize their potential profits. Because why not? Let's spend a little bit. Make a margin. This is all we can spend. Beyond this, we stop. Okay? If you don't get cured, let it be. Okay? That's enough. That's the margin. So the cost minimization analysis is the same as the cost marginal analysis. They have a margin minimization, and in this method of analysis, cost of two or more interventions achieving identical outcome is measured. And therefore, the intervention incurring the lowest cost is then chosen. That's the minimization analysis. What's the minimal cost? It should be strictly noted that the intervention can only be conducted when the outcomes of the comparing interventions are the same. So, if the outcome of the occurring interventions are not the same, there's no comparator. So the cost minimization analysis, or CMA, it is sometimes argued that if the two or more alternatives under consideration achieve the given outcome to the same extent, a cost minimization analysis can be performed. However, it is not appropriate to view CMA as a form of full economic evaluation. Usually, we like to do the CMA as the shortcut, but there are other analysis on economic evaluation that you can have, not just only the cost minimization analysis. Like for this example, incremental effectiveness of treatment. More, same, and less. Incremental cost of treatment compared to control. You can make a chi-square box about this, and you can do some analysis on what should you get more, or the same, or the less. So the possible application of CMA is in situations where a prior view has been taken based on previous research or professional opinion that the two options are equivalent in terms of effectiveness. So, thank you for that time that you spent to me on topic number 3. We're going to go for cost utility analysis now. This is topic number 4, and this is called the CUA. It will explain strength, limitation, and implications of economic evaluation of health programs. So the outcome for today is to explain the strength, limitation, and implications of economic evaluation of health programs, and also design a competent economic evaluation decisions. So the cost utility analysis is more of the utilities. Cost utility analysis or CUA are typically expressed in terms of the cost per healthy year gained or cost per quality of life years gained by undertaking one program instead of another. The utility is usually uh, the equipment of a program, and in this method of analysis, cost incurred in the intervention is measured against the utilities, are called the equipments, or you can call it utilities related to health. They can call it resources, the hard resources, or something that you can touch, tangible resources. And utility refers to the quality adjusted life years, QALY, or the daily adjusted life years, or DALY. And that makes the cost utility analysis undertaking one program instead of another. So, suppose that twins, identical in all respects, are needing incubators on day 2 after born prematurely. Uh, Both need discounts, one needs the incubator discounts and the other one needs also the incubator discounts because they are twins. There's only one incubator left. That's your problem. How do you want to divide the utilities? Maybe day 1 is the first twin, day 2 is the second twin. Those are incubators that you have left, or give them another hospital. Go to another hospital with another incubator. Split them together, even though one twin requires discount and that hospital does not give discount. So that's a fixed cost, and that's what you call the cost utility analysis. If the quality of life years will be as much as what they can pay for, use the resources. This is called the equipment or the resources. So the cost effective analysis compared to cost utility analysis, because you're looking at the effectiveness of the intervention, but now you're looking at the availability of resources, the tangible, hard resources that you can touch, not just the human resources, not just the psychological resources, emotional resources. This is the hard equipment and resources that you can touch. So, both CEAs and CUAs are techniques that relate to constraint maximization. That is why, where a decision maker is considering how best to allocate an existing budget, looks at resources and looks at how to disseminate the resources and use the equipment properly. Now, this VNM utility framework, the von Neumann Morgenstern utility framework, is about taking into consideration uncertainties. Consumer are choosing goods that are not certain sometimes, and the von Neumann Morgenstern utility are a rational consumer that should maximize expected utilities. So these are the von Neumann Morgenstern. Expected utility is the payoff from certain events multiplied by the probability that those events happen. And for this problem to have a solution, the properties of utility functions need to be modified. Some utilities are obsolete, some equipments are obsolete. And in particular, the utility function now has a cardinal interpretation. That's where the concept of risk seeking, risk average, and risk neutral come from. Those are the expected utilities. So the risk seeking utilities as benefits from a gamble should be considered double thought, double thinking. Example, somebody tells you that you can rent the hospital dialysis machine for $100 per session or $200 per week. But there's no certainty that your life will last for more than 12 months. Think again. And what do you prefer? Save the money or seek some risks and gamble the utilities? The utilities are the equipments or the tangible resources are very expensive, think again if there is a risk of using it or gambling to use it. So the risk neutral is showing that there's no risk to take because there are no utilities gambled. There are no utilities that could be gambled because maybe it's free of charge or somebody's sponsoring it. There's a hospital sponsorship or donation companies, and a risk neutral person is indifferent between the option because the expected value of the gamble is likely to occur, and people are not always seeking for neutral, or if the payoff is not affecting the utilities, then go for it. You are just in the neutral side. So the risk average, on the other hand, when we look at risk average, uh, these are a risk that would prefer the utilities rather than the gambling, and not a risk taker. Example: a mechanical ventilator costs $100, for example, per month rental, but there are only a few ventilators available during pandemic, especially in New York, where there's massive amount of people getting into the ICU, and there are only a few ventilators left because New York is crowded. New York is so crowded, and where there is a lot of crowd, the pandemic COVID-19 will occur. You should choose the best person who will survive and not waste utilities or resources. Mechanical ventilation is so expensive, and you cannot just use it for the person who will die. You have to choose and weigh things out. That's what's happening in New York. People are just giving up. Even healthcare providers, they cannot even decide who will get the ventilators because everybody needs ventilator. They cannot borrow from somebody's ventilator or from another state, from another country. They cannot because they have to survive on their own. Other countries are also surviving on their own. They need it for themselves and they need it for their own countrymen. So the risk will not use his own utilities or $100 because there are no winners in gambling. Don't gamble. That's what the risk average is talking about. Look at the average and don't gamble. The utilities are the resources. So the total and marginal utility, the utility that an individual receives from consuming a certain amount of a particular good or service is referred to as that individual's total utility. That's your total utility. The marginal utility of a good or service is the additional to total utility that an individual receives from consuming one more unit of that good or service. That's the margin or the total utility, total marginal utility. And law of diminishing utility. What is the law of diminishing utility? Thus, a marginal utility that one receives from consuming successive units of the same good or service that will eventually decrease as the number of units consumed increases. So, as an example of the law of diminishing marginal utility, this considers the utility that one obtains from drinking successive glasses of lemonade on a hot day. This is the law of marginal utility. So let us explain further. So suppose, because it's diminishing, that means the value is going down. So suppose that the first glass just begin to quench one's thirst. Of course, you're giving out lemonades to quench thirst, and therefore, after two glasses, however, the thirst has all disappeared. The first two glasses can be expensive. That's called the marginal utility because you're using utilities, you're using water, you're using glass, you're using lemonade. Those are resources. Those are tangible resources that you're wasting. The first two are so expensive because the person is really thirsty. And a third glass of lemonade might also provide some utility, but not as much as the second glass. Why? Because a fourth glass cannot be finished because they're not thirsty anymore. Therefore, the utility are useless. In this example, the marginal utility is diminishing, and the addition to total utility that one obtains from drinking lemonade on a hot day is increasing for the first two glasses, but decreasing beginning with the third, and would continue to decrease and diminish if one were to consume further glasses. Therefore, if you want to sell uh, the first utility, make sure they need it. The second utility, they might want it more. But the third utility is no longer of value. It's diminished already. The value has no longer there because you already got the first and the second. Therefore, the cost will fall down because of the demand that is falling down as well. So the cost utility analysis, in this method of analysis, the cost incurred in the intervention is measured against the utility of relatedness to health. That is why there's diminishing marginal utility, there is marginal costs, or the utility analysis. It is also used to make policy or level of decisions. For example, for those who have COVID-19 that are suspected, they can just do the telemedicines. No, those are policies. Don't come to the hospital, You're going to be infected further and you're going to go to the ICU eventually and use all the utilities. So they can have a policy that says, stay home, don't go here. Otherwise, you will overload or overcrowd the entire place. And this place will become overcrowded. So stay home, do telemedicine, call us, and we're gonna take care of you while you're staying at home. Those are the policies that has been established. So when you're trying to make decision models, this is the cost utility analysis decision model. So the quality of adjusted life years gained from an intervention using equipments or using utilities should go higher. The quality of life years should go higher. Of course, if it's diminishing, then the resources or the tangible resources will have no values anymore. If the quality of life years increase, the use of utility decreases. If you're becoming better, you weaned off a mechanical ventilator, and that ventilator is useless anymore because you're being weaned off. You're ready to be transferred out to the regular ward from the ICU, from the CCU. Equipments there are of no longer value to you, and they're diminishing already. Then, the quality of adjusted life years go higher, and the equipments go lower, because you don't need the equipments anymore. You can live on your own. That's the cost utility analysis framework. So thank you for listening for that topic. And now we go to the topic number 5, which is cost benefit analysis. Okay, the cost benefit analysis here on topic number 5 is looking at the strength, limitation, and implications of economic evaluation to health program as well. So what are the learning outcomes? Explain the strength, limitation, and implications of economic evaluations of health programs, and design competent economic evaluation decisions. What is the principle of the benefit? Because there's cost utility, cost effectiveness. Now we're going for cost benefit analysis. CBA is most commonly used for public decisions, policy proposals, programs, and projects. And the benefit itself, same is the name. CBA, it says cost benefit analysis. It is the implicit or explicit assessment of the benefit and cost. What are the pros and cons? What are the benefits? What are the advantages and the disadvantages and associated with particular choice? The benefit and cost may be monetary because you're looking at money for all these economic evaluation, but non-monetary, non-pecuniary, or it can be psychic benefit or psychological impact or emotional impact. They are also the principles of CBA. What are the benefits? What are the psychological benefits of these programs to the person? Does it have a psychological effect? Does it have a psychological benefit? That's the non-monetary. So when you're looking at monetary, you can make money. In this method of evaluation, cost of the intervention is compared with the benefit of incurred intervention. And the net benefit is measured as net benefit is equals to benefit minus the cost. Therefore, if the benefit exceeds the cost incurred during the intervention should be continued because there's a benefit, there's a profit. If I'm the capitalist, I put my capital there. I need to get returns. So, not because there are more people dying, but because there are more benefits that comes to me, or me as a capitalist, the one who incurred with the capital, and therefore I want the best benefit that I can have. For example, I want to rent out mechanical ventilators. What are the benefits that I'm going to have? Or should I give to a lot of cancer patients chemotherapeutic drugs in order for me to get more money? Or should I do fogging and fumigation on dengue infested communities in the public where I won't benefit anything at all? These are volunteers and these are sponsors or donation campaigns. What should I get? So those are the things that can benefit. And sometimes donation companies can have benefits as well. So it's not only those volunteers can get benefit, but also some of the companies, some of the companies have this kind of strategy to get donations because they get 5% from the donation. So imagine if you have a donation campaign for COVID-19 people who are disastered by COVID-19 pandemic, and then you have to get donation to some place else, and out of that donation you get 5%. If those donation comes from World Health Organization and your programs have been approved by the World Health Organization, and you can run this program for pandemic infected people, and you get donations of over 5 million. Imagine what's 5% of 5 million. 5% of 5 million is 250,000. So you get 250,000 in one shot. So those are the benefits. Should I do this program? Am I going to benefit from it? What am I going to do? I'm the capitalist. I need to get something in return. And then the net benefit is equals to benefit minus the cost. How much do I need to spend and how much do I need to get? That's my benefit. Okay, the ratio of benefit and cost. Benefit is greater than the cost, definitely. Must be greater than the cost. If the benefit is lesser than the cost, forget it. The net benefit or dollars, or net benefit or NB is equals to benefit minus the cost. If you get more cost than the benefit, more benefit than the cost, then you get zero. Okay, forget it. The results of such analysis might be stated either in the form of a ratio cost to benefit or as simple as the sum of possibly negative representing the net benefit or loss of one program over the other. So, am I getting benefit or loss? Those are the opposite. The opposite of benefit is loss. Net social benefits, the total benefit to society from producing or consuming good service, is called the net social benefit. So, it includes all the private benefits plus any external benefit of production and consumption. And the marginal social cost as the MSC, these are the additional marginal social benefits from one more unit of output. And the additional social costs of producing one more unit of output are the different theories of cost-benefit analysis. NSB and MSC. Net social benefit, the net, includes all of it, all the private benefits plus any external benefits and production, the net. While the marginal social cost is the additional marginal social benefits from one more unit of output. An additional social cost of producing one more unit. That's the marginal social cost. So, the net social benefit is the total social benefits plus the total social cost. Those are the net social benefits. You add them all together, all the total benefits and all the total costs. That's the net. The net. If a good has a significant external benefit, then the social benefit will be greater than the private benefits. But this is still the net. You're looking at the net. Combine them all together, summation, and that's the net. So the marginal social cost the MSB or the marginal social benefit is equals to the decision multiplied by the total social benefit divided by the decision multiplied by the the, the Q, or the quantity of a publicly provided good or services. So, did you decide on the quantity? How much did you decide? While the marginal social cost is the decision multiplied by the total social cost divided by the decision multiplied by the number of quantity. And usually choose the decision that because of the marginal social benefit, not the marginal social cost. Because the marginal social cost is the additional cost, and the net the net of that social benefit are maxed out when the marginal social benefit is equals to the marginal social cost. Therefore, you are losing on the marginal social cost rather than gaining from the marginal social benefits. Remember, the net social benefits can be maxed out if they are equal to each other. So, aim that the marginal social cost, the additional cost that you put on, should be lesser than the benefit that you're looking for. Reduce the cost, gain the benefit. Willingness to pay method, it translates effects such as disability days avoided, or life years gained and medical complications avoided, or quality of life years gained into a monetary value that can be interpreted alongside cost. So the marginal willingness to pay, or MWTP, measures how much consumers are willing to pay for a benefit. This is the very tricky thing which insurance company does, because imagine insurance company can get bankrupt if everybody has benefits. So how do they get the benefit from all these um, these promises that they give as the benefit that they give to the client? Insurance company will always ask you to declare disabilities, declare your primary health disability, or declare whatever health status you have, and you will be disqualified, and in that way they gain more benefit than you getting money from them. Capitalism is getting money from you, not giving money to you. Therefore, they will ask money from you, but they will ask you to declare. For example, you have declared that you have diabetes, then you are disqualified from any benefit of diabetes occurring, because they want quality adjusted life years gained into a monetary value that can be interpreted alongside cost. The longer the quality adjusted life years, the more benefit the insurance company gets. And your willingness to pay method will not give them the legal lawsuit, because you signed the contract, you're willing to pay despite of being disqualified from that benefit. That's the trick of the marginal willingness to pay. Capitalism is always like that. You will never win on capitalists. So the cost benefit analysis looks like this: description, initial cost, year one, year two, and the total. You get these templates for you to get the cost benefit that you're looking for. What are the benefits that you can get from year one? What are the benefits that you can get from year two? Total them together, and you get the net. And that's where you get the analysis whether to pursue the program or not. And thank you for that topic number 5. We're staying on with topic number 5. And now we're already on topic number 6, which is decision analytic model. So this topic number 6 is to design a competent economic evaluation decision. So the course learning outcome is to explain the strength, limitation, and implication of economic evaluation, and design a competent economic evaluation decision. So the decision analytic is more likely for a healthcare evaluation model with logical mathematical framework to permit an integration of facts. You're now integrating facts and values that links these data to outcomes that are of interest to healthcare decision makers. And its purpose is to structure evidence on clinical and economic outcomes to help inform decisions about clinical practice and healthcare resource allocation under conditions of uncertainty. So the context of decision analytics is in the context of economic evaluation, a decision analytic model uses mathematical relationships to define a series of possible consequences, such as health and economic outcomes of patients or population that would flow from the alternative options being evaluated. This is the concept of decision analytic. You have to make a concept or an illustration, and quantifying probabilities and outcomes are also one of the tricks of doing a decision analytic model. Now, based on the inputs of model, the likelihood of each consequences of health economic outcomes of patients or population is expressed in terms of probabilities. And each consequence has a cost and an outcome. Risk of exposure to bacillus, like for example, probability of zero point 0.2, that means high risk. Okay, that means rejected probability. Risk of contracting meningitis if exposed is zero point 0.1. Again, it's rejected probability. Efficacy of the vaccine, risk of meningitis if vaccinated, again, it is less than 0.05. That is a good probability wherein you can get that program done. And the risk of associated with vaccines of risks, for example, having uh, having side effects of sleepiness, having side effects of forgetfulness, having side effects of body malaise or body weakness. These are risk associated, and it will occur because it's less than 0.05. These are the probabilities. Quantifying it, making it mathematical, is what the trick of making decision trees all about. So the decision trees are decision options. Option number 1, 2, 3, 4, that's a tree. It's like a branch, branching out into many, many stages. And these models are visual representation that you can see. Let the decision maker be the client because you're not the decision maker. The key decision makers on decision trees are the client themselves. Give them options. These are the options. And they are used to illustrate decisions in comparison to the other alternatives. By modeling the various expected outcomes and their probabilities, businesses can then select the decision that produces a favorable outcome. So this is an example of decision tree. Vaccinate or do not vaccinate. If you do not vaccinate, you die. If you vaccinate, you get exposed or not exposed. So that is the decision tree, and that is where they make their own decisions. And remember that the client are the key decision makers. So expected values, after model is constructed, it is important to find the expected value to evaluate which decision should result in the most favorable outcome. So recall that decision tree and provide all possible outcomes in comparison to the alternatives. And by calculating the expected value, we can observe the average outcome of all decisions and then make an informed decision. That's what you call the expected value. So the expected value formula is probability A multiplied by payoff A plus probability B multiplied by expected payoff of A, and that's your expected value. This formula assumes that a business decision has two outcomes, success or failure, and each outcome can be represented by probabilities, A or B. You can have C. The expected payoff refers to the gain or loss expected with each outcome. Program budgeting. This is the most important thing that you must do. You must budget your program because budgeting is a managerial skill. And therefore, if you're the manager, you have to have the budgeting skills. And choose the bigger budgets that can give a good effect. Or choose the lesser budget that can give more effect. A program budget is a budget prepared specifically for a program or programs or projects. And this type of budget includes expenses and revenues. Revenues are what you invest and what you get in the investment. Related to one specific project, no revenue or expenses of any other projects are mixed with this particular project. Therefore, you have to have a good budget so that you can capitalize and then you can get benefit. And if the program does not look at the quality adjusted life years, then the budget will fail. As what I said just now, it's either a failure or a success of your budgeting program. So that's it for the whole sixth topic of economic evaluation in healthcare. And I'll expect you to have a very good ass- assignment um, for this subject. Thank you very much for staying for six topics. And I'll say goodbye to you now. Bye.